Today we are going to learn something about frozen shoulder and the technique hydrodilation. Frozen shoulder is also called as adhesive capsulitis, and it causes a lot of pain and stiffness in the shoulder. The incidence of frozen shoulder in the general population is approximately 2%. It most commonly affects people in the age group of 40 and 60 years, most commonly in women, then in men. Also, it is commonly seen in patients with diabetes mellitus. It is 5 times more common. Patients with cervical disc disease, prolonged immobilization, hyperthyroidism, stroke or myocardial infarction. Here what happens is that the shoulder capsule thickens and it becomes stiff and tight. Thick bands of tissue, which are called as adhesions, develop. In many cases, it is found that there is less synovial fluid in the joint. Now there are 3 stages of the frozen shoulder. The first stage is the freezing stage, in which the patients usually have a gradual onset of diffuse shoulder pain, which is progressive over weeks to months, with the pain usually worse at night and exacerbated by lying on the affected side, which is followed by the frozen stage. Here the patient, because of pain, gets pain relief by restricting the movement, leading to the stiffness phase or the frozen phase that lasts for 4 to 12 months. In this phase, the patients describe difficulty with activities of daily living. This is followed by the thawing phase, in which there is complete return to normal or close to normal range of motion that typically takes 6 months to 2 years, with improvement in the pain as well. The various non-surgical treatment options that we have in frozen shoulder are non-steroidal anti-inflammatory drugs and physiotherapy. If it fails, we can give steroid injections, or also we can do hydrodilation procedure. We had a patient, a 50-year-old female with 4 months history of frozen shoulder, who had limited active and passive range of motion of the right shoulder joint and had difficulty in activities of daily living. Here we can see the pain and stiffness the patient has in her right shoulder joint, and she has difficulty in doing activities of daily living. Now for the subacromial injection and hydrodilation, we need to clean the skin with spirit and betadine. I'm palpating the spine of scapula, going to the acromial angle, and the injection site is around 1 to 2 centimeter below and medial to the acromial angle. Now it is very important to correctly identify the entry point of the injection. You can mark it with the cap of the syringe. Now what I'd be doing here, this is the acromial angle, and just around a centimeter or 2 down and medial to the acromial angle, the syringe is directed towards the coracoid process. The injection that I am using right now is triamcinolone injection, 40 mg with 2% xylocaine. Now first of all, we need to aspirate and then inject. The injection should go smoothly without any resistance. That would be one of the key indicators that the needle is in the correct position. Now as you can see in the video, that my left hand is stabilizing the needle. After I injected around 10 ml of the previous solution, I am now injecting 10 ml of normal saline. So total of 20 ml has been injected right now into the patient. After that, again I am refilling the syringe and again injecting another 10 ml of normal saline. While I am injecting the saline, I am constantly asking the patient about any discomfort or any problem that the patient is having. She was comfortable during the procedure. This would be my 4th injection. Another 10 ml of normal saline saline is being injected, and again after injecting this 10 ml of normal saline, I have taken another syringe filled with 10 ml of normal saline. The idea of hydrodilation is to inject as much amount of sterile fluid into the area of the capsule so that it gets distended, or you might even rupture it. So as long as the patient is comfortable, I would inject the normal saline. So this is the sixth injection, the fifth injection of normal saline. Total sixth injection that has been injected in the subacromial space, and after that the needle would be removed and the area cleaned with betadine swab. Here the patient, after injection, you can see that the patient is comfortable and is able to raise the arm, which was earlier very difficult and painful for the patient. Now you can see the range of motion quickly improves within a span of 2 to 5 minutes, and the patient is pain-free, and the range of motion of the right shoulder joint has drastically improved. And the another thing that you can do is ask your patient to move your fingers up on a wall, and here you can see the patient is completely able to extend the shoulder joint, which was earlier very painful and difficult. Thanks for watching.